Welcome, and thank you for tuning in to Derm Docs, powered by LiveDerm. This special episode marks the kickoff of a new series hosted by expert dermatologist Dr. Christopher Bunick, who will be discussing the evolving role of JAK inhibitor therapies in the management of atopic dermatitis, with various guest speakers featured over the next several months. Thank you again for joining us for our first episode, The Spectrum of Atopic Dermatitis and the Emerging Role of JAK Inhibitors, featuring Dr. John Koo.
Hello, everyone listening in. I'm Chris Bunick, and it's a real pleasure to kick off this entire series of podcasts on systemic JAK inhibitors and atopic dermatitis, really understanding their clinical role in atopic dermatitis. We're going to focus on clinical facts and some of the science that supports those facts. And today we have our kickoff expert, Dr. John Koo, joining us, and we're going to really dive in to kind of a bunch of issues on atopic dermatitis. And, John, the first thing I'd like to do to kick it off is ask the question, what is atopic dermatitis spectrum disorder? I noticed in PubMed, you have a couple publications talking about atopic dermatitis spectrum disorder. And I think for our listeners out there, what does that mean?
Oh, Christopher, thank you for asking, and thank you for having me here. The terminology atopic dermatitis spectrum disorder, I have to admit, I kind of invented it. And the reason that I emphasize on spectrum disorder is because that's a concept that is well accepted outside of dermatology. As many audience might know, I'm actually a dermatologist and a psychiatrist. And one thing I noticed with atopic dermatitis is not like psoriasis. It has such a heterogeneous manifestation, ranging from every subtype of eczema, even to the sequelae, of chronic itching, such as lichen simplex chronicus, prurigo nodularis. And the real problem is the same patient can present differently at different times. Sometimes they might have classic, like antecubital popliteal fossa kind of rash, and other times they might only show lichen simplex chronicus, or they might only show part of it, like eyelid dermatitis, nipple dermatitis. And the other problem is that nowadays dermatologists are asked to see more patients with less time. So there's a real temptation, a real danger of just looking at a patient and say, oh, you have hand dermatitis, and put that as a visit diagnosis, or you have lichen simplex chronicus and put that as a visit diagnosis, when in fact, if you dig a little deeper, you find out this patient actually have atopic dermatitis. But if the diagnosis is like lichen simplex chronicus, eyelid dermatitis, nipple dermatitis, hand dermatitis, the patient cannot get all that good treatments that are available because everything that's approved for atopic dermatitis become off-label. So out of this concern, I, along with my collaborators, decide to put spectrum disorder in the map of dermatology. And we ask if we agree that atopic dermatitis is in fact a spectrum disorder with truly heterogeneous manifestation, instead of like psoriasis, which has a lot more defined and limited expression. And we got nearly perfect agreement, and that's one of the publications. So the whole effort is to try to get patients the treatment they deserve, treatment options they deserve, by not missing atopic dermatitis altogether, by looking, it's like missing the forest for the tree, just looking, focusing on partial manifestation. Sorry, I talked for too long, but that's what it is.
So one of the things I really liked in your paper was this concept of thinking about eczema as a family. And you talk about being a lumper or a splitter. And I think dermatologists are, when they think about diseases, sometimes they're lumpers and sometimes they're splitters. And I think that here with atopic dermatitis, that there are opportunities for lumping and there's opportunities for splitting. And what we're talking about here is that all of the splitting of atopic dermatitis into all of these different subsets of eczema, they really fall under a big umbrella of atopic dermatitis phenotypes. And there's many different ways in which atopic dermatitis can present in patients. And these are the different phenotypes or phenotypic presentations that our patients that present to us in clinic every day. And it's very important for us as clinicians to recognize that atopic dermatitis or eczema doesn't always follow the textbook, and that there are these varied presentations. And the patients themselves, yes, they have rash, but they're still also suffering different forms of scaling, different forms of itch, and other things like sleep disturbance. And so recognizing the atopic dermatitis spectrum, I believe, is incredibly important for making sure that we don't miss patients that don't fit the textbook, right? Our goal is to bring therapies. We have a lot of innovative therapies that we're going to talk about in this podcast and the future ones. But the idea is that there's so many innovative therapies. If you limit AD to the textbook definition alone, you're probably missing a large proportion of patients that present with atopic dermatitis, but more phenotypes that are not as common or don't fit that textbook. And we want those patients to have access and get all of these wonderful therapies that are coming into the atopic dermatitis space. And so, Dr. Koo, what do you think about how the concept of atopic dermatitis spectrum?
We are hoping that it's going to impact in a way that the patients optimally treated because of the effort to make a more accurate diagnosis instead of missing atopic dermatitis altogether by simply focusing on a partial manifestation. And it's really not that difficult to dig in. In my practice, I only need to ask two questions. One is, besides what you're showing me today, talking to the patient, did you have other rash in the past? Now that's so obvious. That's just taking past medical history. Amazingly, we find that when the dermatologists are rushed, they may not take that extra effort. So the one question, once again, is what kind of rash did you have in the past? Did you have anything else besides what you're showing me? The second question is pretty obvious. Have you had personal or family history of eczema, asthma, hay fever, and food allergies? And if these two questions, if the answer is yes, then what we advocate, myself and other experts who join me for this consensus, is don't put things like hand dermatitis right away, like a knee-jerk kind of a reaction. Instead, put atopic dermatitis if the answers to those two questions are yes. And then in the note, what we put is the patient has atopic dermatitis spectrum disorder today manifesting as a hand dermatitis, or today manifesting as prurigo nodularis. Now, Christopher and I agreed the thing about lumper and splitter. And that's actually, believe it or not, exactly how this whole concept of spectrum disorder came about in psychiatry. Because as you know, in psychiatry, we have DSM-3, DSM-4, now DSM-5. This is like a psychiatric Bible of diagnostic criteria. And those criteria in psychiatry, like in dermatology, is mostly defined by academicians. And academicians tend to be splitters, not realizing that if you're a splitter and you make the diagnosis narrower and narrower, more and more people are left out of treatment.
So one of the things that you said that I really resonated with, so for all of our listeners that when they're talking to their patients, I agree. One of the questions that I love asking patients, and in particular, parents of young children that have atopic dermatitis, is their family history of either eczema, seasonal allergies, or asthma. Because I think that once they understand, more often than not, I find that there's some family history of atopy in these patients. And once you can explain that these diseases, these kind of Th2 driven diseases, are genetically linked, I think that it helps parents as well as patients themselves understand why they have atopic dermatitis, but also it helps understand. So all these different phenotypes that we've been talking about, it also helps put it into like a genetic and family history perspective once you understand the nature of atopy within a family tree. And we were talking, going back to the phenotypes in atopic dermatitis, we talked about that this concept that AD doesn't always present in one way, right? We can have, you mentioned hand eczema, you can have hand eczema, you can have flexural eczema, papular eczema. Some patients just have bad itch with very little rash. There's prurigo head and neck eczema, and there's many others. But what underlies these phenotypes? And I think one of the biggest things that's changed in the last few years is a better molecular understanding of the cytokines and the immunology behind these phenotypes. And one of the words I wanted to throw out there is what's called the molecular endotype. So phenotypes describe the clinical presentation of a patient. What's called the endotype is describing kind of the immunological profile in the tissue that may be driving a specific phenotype, right? And so what we've learned is that a patient may present with two different phenotypes. It may all be atopic dermatitis, but when you look at the cytokine profile, maybe one patient has more elevated IL-4 and IL-13, and another patient may have a little bit of skewing of cytokines towards Th1 and Th17 axis, such as more interferon gamma, or maybe they have IL-22. And we obviously know there's other cytokines involved in atopic dermatitis, like IL-31, TSLP. So there's a number of things that can contribute to this molecular heterogeneity. And what we're learning is these endotypes, or these molecular differences, may underlie some of this phenotypic difference that we're seeing and this may account or help explain from a scientific level the concept of the atopic spectrum disorder. And going further about the heterogeneity in AD, so Dr. Koo, it sounds to me like for years you've recognized this heterogeneity, and how are you reconciling the fact that now we're seeing or reviewing atopic dermatitis as a multiple cytokine disease? Does that kind of fit with your notion of the heterogeneity of atopic dermatitis?
Yes, Christopher, it definitely fits. I totally agree that the more recent scientific findings seems to give validation to the whole idea that atopic dermatitis is both heterogeneous and a spectrum disorder.
Yeah. So the truth is, Dr. Koo, that there's probably a lot of listeners that also feel the same way. What is an endotype, and why does that matter clinically? And I think that the simplest way to distill it down is that we're now recognizing that the spectrum of atopic dermatitis, the way patients present, that there's a very complex immunology that underlies that. And this involves multiple cytokines, not just IL-4, IL-13, like I said, IL-31, IL-22. There's even some patients that have, like I said, Th1, Th17 skewing, IL-22, maybe even IL-17, as well as interferon gamma. And a lot of people don't realize interferon gamma can downregulate ceramide synthase. And so that can affect ceramides in the skin barrier, which is also an important component of atopic dermatitis. But ultimately, the endotype is explaining this complex immunology. The endotypes explain that the cytokine profile for a given patient with a given phenotype, they may be different. But in the end, it is all lumped under this atopic dermatitis spectrum. The spectrum of the clinical presentation, there's also a spectrum of the cytokine elevations or dysregulation on the immune side. And I think that's a great way to think about it. And I do believe this heterogeneity impacts treatment outcomes and patient management because depending on the cytokines or the endotype driving a certain phenotype, a patient may be more suited towards one medication or another. So Dr. Koo, we know that in this innovation era in atopic dermatitis, we now have a lot of biologics that are targeting one or two cytokines at a time. And now we have also these advanced oral systemic agents, the JAK inhibitors, which can inhibit multiple cytokines at a time. And there are more agents in development. And then we have our traditional immunosuppressants that we've always had. So there's a huge amount of options for providers to treat atopic dermatitis patients. But in your experience, how are you approaching the treatment of atopic dermatitis patients given this underlying heterogeneity?
Well, first of all, with regard to endotype, as I understand from your explanation, endotype is like subgroup within the diagnosis. It's almost like atopic dermatitis, if that is to say mankind. Endotype might be, French, Chinese, Middle Eastern. Is that okay to simplify the idea of endotype like that, the subgroup within the overall umbrella?
Well, I think that, so I think you raise a good point. I think that the hope is in the future that we have bedside diagnostics, right, where you're able to do some type of quick bedside diagnostic that says, oh, you're atopic dermatitis, IL-13 driven or IL-13 predominant, or your atopic dermatitis, you're interferon gamma predominant, or atopic dermatitis skewed towards IL-22, right? It'd be really cool to have that technology one day to be able to really rapidly be able to understand those subgroups. I don't know that we're there yet. I know that there's companies trying to get there, but that level of subgroup analysis is coming. And I think that one of the reasons it's coming is because our therapies are becoming more and more targeted to, certain cytokines, and therefore we're forced to understand the cytokine heterogeneity behind atopic dermatitis.
I think that also what you're talking about, endotype and heterogeneity, might also explain why JAK inhibitors generally tend to work pretty well and pretty fast because JAK inhibitors are capable of blocking more than one or two cytokine, whereas the biologics are so precise, so specific. If it goes after cytokine, it might only block one cytokine. If it goes after receptor, like dupilumab, it might block two cytokines, but that's about it. But if you use JAK inhibitor, because you are more downstream in interrupting the inflammatory signal, you actually end up blocking not just interleukin-4, interleukin-13, but a whole lot of others, including interferon gamma that you mentioned. And I think that may eventually explain, why JAK inhibitor has that kind of efficacy and speed of onset.
Yeah, I think you're exactly right. And this leads into the kind of the next section of what I wanted to talk about, and that is the mechanism of action of the JAK inhibitors, and kind of setting up. I think we set up very nicely this heterogeneity concept. And one of the reasons exactly that the JAK inhibitors are displaying in clinical trials and in real world evidence this fast onset of action, as well as this more robust, so to speak, clinical response, right? Achieving EASI-90 at really high levels, achieving itch 0 or 1 at really high levels. I think that one of the reasons the JAK inhibitors are able to achieve that is exactly because it can address multiple cytokines, the molecular heterogeneity. It's able to also disrupt IL-31, TSLP, IL-22, interferon gamma, the IL-17, all of that. It's able to do all of that. And I do think that that plays a huge role. But when I think about treatments, so just to back up and look at mechanism of action, I do think that it's very important to keep it very simple, especially when you're explaining it to patients. I like thinking about, we have biologic injectable medicines. They work outside the cell, right, by targeting either the receptor or the cytokine of that's binding to that receptor outside the cell. So you're getting at the early binding step of the signaling process, whereas the JAK inhibitors are working inside the cell, right? And they have they're working right at those proteins, the JAK stat proteins that are through phosphorylation are transmitting that signal inside the cell down into the nucleus to affect transcriptional programs. So we have outside the cell and we have inside the cell. And I also think that one of the reasons you have this fast onset of action of the JAK inhibitors and patient efficacy is because that you're targeting the machinery, the signaling machinery, right inside the cell. And this is, I think, an important advantage. And we know that JAK inhibitors as a whole target either JAK1, JAK2, JAK3, or TYK2. And yeah, I know there's people out there that want to think of TYK2 as it's not part of the JAK family. And I don't think that's true. TYK2, JAK1, 2, and 3, very clearly, when you look at phylogenetic analysis, are evolutionarily related. These four are all part of the same family. And I think that one of the biggest concepts to grasp is that not all JAK inhibitors are created equal. And I think that this is a concept that we haven't quite gotten to in dermatology yet, but they're not all created equal. They have different selectivities, and we're just beginning to parse out how the science of the different selectivities play a role in the clinical response, as well as potentially safety profiles. And so I just, in your experience, Dr. Koo, what have you seen? How is the mechanism of how JAK's work played out in your clinic? And how does that compare to possibly some of the traditional systemic agents that you've used in terms of efficacy and safety?
Well, first of all, it plays out with exactly what you said. Very impressive efficacy overall, especially impressive quick onset of action. And compared to the traditional agents like systemic steroid, methotrexate, cyclosporin, I think the safety is so much better. But with regard to the safety, I kind of feel personally, this is just my personal opinion, really bad for Americans. And the reason I say that is because I just got back from Japan. I was giving a lecture for up and down Japan for almost 3 weeks. And I realized that they have JAK inhibitors for atopic dermatitis, abrocitinib, upadacitinib, even baricitinib, which is not approved in US. But what they don't have is the black box warnings that we have. And the reason they don't have the black box warning like the one we have is because their FDA, Japanese FDA, is evidence-based. American FDA, I'm sure they care to some extent about data and evidence, but they care more about maximum warning. They make medications look as scary as possible. So I'm going to make this really quick, but when I review that actual data for abrocitinib and upadacitinib, none of the black box warnings are evidence supported. In fact, they are evidence refuted, except for herpes. Herpes simplex, herpes zoster, yes, that was at least higher than placebo. But when it comes to serious infection, the highest dose of upadacitinib and abrocitinib had a serious infection rate half of the placebo, approximately only half of the placebo. When it comes to mortality, there's hardly anybody who died. Neither one of them had anybody who died who was thought to be because of the medication. In fact, upadacitinib had nobody die within the first year of worldwide phase 3 study involving about 3,000 patients for upadacitinib, 3,000 for abrocitinib, so out of about 6,000. Malignancy, abrocitinib had only 2 malignancies. Both of them were prostate cancer in elderly men. Upadacitinib had only 1 who had CTCL, who was thought to have CTCL from the beginning, but was allowed to be in the study because 2 biopsies did not prove that it's CTCL. Day 194, they couldn't stand it, did another biopsy, it was CTCL. That was the one and only non-melanoma skin cancer in upadacitinib in the first year. MACE, once again, hardly anybody was thought to be related to the study. And thrombosis, which is the last one, upadacitinib, the highest rate of thrombosis was the placebo group. And abrocitinib had two PE, both patients on long-term estrogen, and one DVD, clearly related to arthroscopic knee surgery. So it's pretty amazing that the data doesn't support the black box warning except for herpes. And Japanese don't have to worry about that because their FDA is not into this type of non-data-based kind of warnings.
Yeah, so John, I agree with you completely. I think that the boxed warnings and the reaction to them when JAK inhibitors were first launched was overblown. I do think that over the last year, we've made a lot of headway in education around the boxed warnings, and particularly by reshaping the narrative that focusing on the efficacy and the safety, the long-term safety of the JAK inhibitors. When I'm lecturing about the efficacy and safety of JAK inhibitors, what I say about the boxed warnings is this. In dermatology, we have over 50 medicines with boxed warnings. I don't think there's any other specialty that's more trained to handle medicines that have a warning on the label. But more importantly, just because something has a boxed warning, it doesn't mean don't use the medicine. Over-the-counter ibuprofen has a boxed warning. In fact, for some of the same cardiovascular risks that some of the JAK inhibitors have. And so my point being is that boxed warnings really just mean do your job as a doctor and take care of the patient. And I think that what really has happened over the last couple of years is that as more long-term safety data has come out about JAK inhibitors, we've learned that they're actually maybe way safer than we could have ever imagined. And this is why I even will go so far as to say that I think there's a time in which JAK inhibitors will be first-line therapy and atopic dermatitis and potentially other indications as well. Over the last several lectures that I've given from the podium, one of the things that I've emphasized is that the JAK inhibitor rates of whether it's clotting, cardiovascular disease, or cancer tends to actually be lower than some of these baseline rates. And I think that that's a very, very important distinction, showing that the JAK inhibitors are actually an incredibly safe group of medicines to use, at least certainly in the atopic dermatitis patient population. And I'm really glad you brought up herpes zoster, because at least in the upadacitinib long-term data, it's important to understand less than 5% of the patients in the upadacitinib trials that are being used to generate the long-term safety data, less than 5% had shingles vaccine. And so this raises an important question. So Dr. Ku, do you ask your patients to get shingles vaccine? Because that herpes zoster rate could have been way less if most of the patients had a shingles vaccine potentially.
Yes, if they are old enough to qualify for shingles vaccine, I recommend that they get that first. But I'm very glad that we are both addressing this safety issue. One other thing that I just want to share with everybody, I think by now most people know that the black box warning for abrocitinib, upadacitinib all came from tofacitinib, oral surveillance study with rheumatoid arthritis that was purposely enriched for risk.
Yeah, I agree with you. I think that as more and more facts come out and long-term safety data comes out, again, I think we're in agreement here that the JAK inhibitors are proving to be safer and, of course, more effective and more safe than we could have ever imagined. And I think that this bodes well for this innovative class of medicines in atopic dermatitis and certainly in other diseases. And I think that we sort of touched on this, but what about studies, head-to-head studies that kind of show some comparison between the efficacy of the JAK inhibitors versus biologics? Are you able to comment on that at all?
Oh, yes. And there are many head-to-head studies. Consistent result. JAK inhibitors, both abrocitinib and upadacitinib, at the higher dose especially, but clearly more efficacious than dupilumab. But even the lower dose has a faster onset consistently than dupilumab. So I think the efficacy of JAK inhibitor being superior to biologic, I think that's pretty clear.
Yeah, so I think you're speaking towards at least the two trials that I'm most aware of, are the Heads Up trial comparing upadacitinib 30 milligram dose to dupilumab, and then the JDARE trial comparing abrocitinib 200 milligram daily dose to dupilumab, the 300 milligram every 2 week dose. And I think both those trials kind of had the same conclusion, and that was that the JAK inhibitor performed better than dupilumab over roughly a 24 to 26 week time period. But it had a rapid rise, a very rapid efficacy, as well as rapid reduction of itch. And I think that was really one of the hallmarks of that trial, was just how quickly the JAK inhibitors distinguished themselves from the dupilumab. I think that sometimes a good example is very helpful. And so for all our listeners, all our practitioners out there that are really excited about JAK inhibitors and want to use them, do you have a really good patient case that you'd like to share?
Well, I have many good patient cases, but they're all boring because nothing horrible that happened to them, which I'm not surprised because once again, the black box warnings other than herpes, the simplex and herpes zosters were not database anyway. So people are delighted when they have quick improvement, especially with regard to itching. And now the actual database side effect besides herpes is only acne, nausea, and headache. But among my patients, I have seen acne, but they're generally pretty minimal. And nausea seems to be hardly present. And even if it were, it's transient. And I haven't seen much headache at all in my patients. So yes, I have many memorable patients. They're memorable because they're grateful. They are very impressed. But as I said, kind of boring because nothing spectacular happened in terms of side effect.
So I'll share a story to complement that. One of the patients that I had was roughly a 25-year-old Caucasian male, had been on dupilumab for a couple of years. And yes, it helped. I would say that he was maybe from a skin perspective, he was maybe 50% better. From an itch perspective, maybe he had gone, from maybe like an 8 on the itch numeric rating scale down to a 4 or a 5. So you would say that, hey, maybe as a doctor, I did a really good job. I was able to get him 50% better in his skin, and maybe I was able to cut his itch in half, but he wasn't satisfied. And so I switched him to upadacitinib, and remarkably, completely clear skin, completely reduced itch to 0 out of a 10-point scale, the itch NRS scale. But what was really fascinating is that he did so well that he started to forget to comply with his medicine. And so to me, the biggest issue I have with patients and JAK inhibitors is nothing to do with safety. And frankly, I see very little acne or nausea or headache, as well as you mentioned. What I see is the non-compliance. And so this patient was doing so well that he would stop his medicine. And he described it like a light switch. The day that he stopped his medicine, the itch would start coming back. He remembered to take his medicine, itch was gone. And he described it as this light switch, on, off. And that was how effective, but also how rapid the JAK inhibitors were able to work. And so I think this was a really important patient for me, just to be able to understand how the JAK inhibitors can work in patients that have previously responded, but not partially responded, not a complete response to dupilumab, what the JAK inhibitors may be able to offer beyond that, but also learning some of those important patient conversations about compliance, that hey, you really need to be compliant with your JAK inhibitor so that the effect continues and is sustainable. So going into kind of our last section that we're going to talk about today is the role of traditional agents. So I had the privilege a year and a half ago to publish a paper in the Journal of Drugs and Dermatology where my research group asked a specific question. So by research group, in this case, it was a medical student, Stefano Daniele, and myself. We asked a very specific question, and that was, while everyone was very worried about the boxed warnings, we just asked the question, were the JAK inhibitors safer than traditional immunosuppressants? Because when I was a resident, I remember that if you were prescribing methotrexate, cyclosporin, or even systemic steroids for your atopic dermatitis patient, and you were getting them better in the pre-dupilumab era, you were patting yourself on the back saying, I'm a really good doctor. This is amazing. I did such a good job for my patient. And the reality is that what we found, and again, we were using the data available, which there hadn't been a lot of careful documentation of the traditional immunosuppressants in atopic dermatitis patients, but using all the data available, we found that the JAK inhibitors had lower adverse event rates of special interest, the clotting, cardiovascular, and cancer, than the traditional immunosuppressants. And to me, this was a big eye-opener because it suggested almost immediately out of the gate that the JAK inhibitors should be positioned ahead of traditional immunosuppressants in that treatment pyramid. And certainly the hope is going forward, and we mentioned this limitation in our paper, but the hope was going forward as we get more atopic dermatitis specific data that this analysis could be refined. But to date, there still isn't any other data that suggests otherwise, that the JAK inhibitors truly are safer than the traditional immunosuppressants. And so my question to you, Dr. Koo, is there any relevance to the traditional immunosuppressants in atopic dermatitis going forward, especially with the American Academy of Dermatology, their new atopic dermatitis guidelines, which actually give the traditional immunosuppressants a conditional recommendation?
Yes. First of all, atopic dermatitis, we all know, is a chronic condition for most people. We're talking about long-term disease. So for long-term use, not 2 weeks, not 2 months, maybe not even 2 years, but perhaps for decades, I think traditional immunosuppressants are not recommended. If we can avoid them, that would be the best. And that includes systemic steroid, cyclosporin. So in my practice, when I have to use traditional immunosuppressants, usually for 2 reasons. One is if the patient doesn't have any insurance or doesn't have real financial problem to get any of the newer medication. That's one. The second is that the patient do have reasonable insurance, but it takes time for the medication to actually get approved and become delivered to the patient. Meanwhile, if the patient is in great distress, then I'm going to use whatever's available to just get the patient immediate relief. And this is strictly short-term use. I think things like cyclosporin or systemic steroid are most ideal when it's used very short-term, but becomes not good when it's used long-term. So those are the 2 situations where I still have to perhaps use traditional agents if the patient have difficulty obtaining anything better for immediate relief.
Yes. So what I'm hearing is that there is still a place, but a very limited place, for using traditional immunosuppressants in a short-term capacity for certain patients that just really need it and can't get access to the more advanced either biologics or the systemic agents like the JAK inhibitors.
Yes.
And I think that fits with the conditional recommendation from the AAD guidelines. And you mentioned corticosteroids, and I think that you and I agree on this, that there's really a very, very limited place for the systemic corticosteroids, certainly long-term systemic corticosteroids in the treatment of AD. And this is why the AAD, atopic dermatitis guidelines, actually recommend against the systemic corticosteroids in the current treatment landscape of atopic dermatitis.
Yes, I think in my personal experience, long-term systemic steroid is, in terms of side effects, worse than cyclosporin. And cyclosporin is not as good as any of the new agents that we have for long-term use.
Ironically, going back to the boxed warnings, right? Methotrexate, and cyclosporin have boxed warnings, but systemic corticosteroids do not.
That's very ironic.
It is. So is there a specific way when you're treating your patients that maybe are on traditional immunosuppressants? How do you transition them from a traditional immunosuppressant to a JAK inhibitor?
Well, first of all, I have to explain to them about that well-known risks, established risk of traditional immunosuppressants, whether it's cyclosporin or whether it's internal steroid. And to me, those are something that we already know from decades of experience. On the other hand, JAK inhibitors, as I have already outlined in detail, every one of the black box warnings are speculative, refuted by actual evidence, except for herpes simplex and herpes zoster. So in case the patient is worried about it, because nowadays people can actually Google and find out about the box warnings. So it's better if they are informed ahead of time that none of that black box warnings are evidence-based except for herpes. And the real side effect is only acne, nausea, headache, and herpes. And when I put it that way, the patients are much more comfortable transitioning. And I do explain to them that I may have to overlap a little bit between JAK inhibitor and whatever they were on before, but overlap is minimal because JAK inhibitor start working so fast. It's not like biologic where I have to overlap for weeks or months. And the last thing that I tell the patient is that there's a huge difference between JAK inhibitor and biologic, apart from pill instead of needles. And that is that the biologics are always vulnerable to biologic fatigue, what we call secondary failure, where even if the biologic works really well initially, over time, it can actually work less, and eventually it could even stop working because every biologic has a possibility of anti-drug antibody, the ADA, making it less effective, and we don't have any way to counter that. Whereas JAK inhibitor is not a protein. Nobody's going to make antibody against JAK inhibitor. So we don't have to worry about secondary failure or biologic fatigue. And usually with those merits, patients are happy to transition to JAK inhibitor.
Oh, thank you, Dr. Koo. That was very eloquently said. So I think we're nearing the end of this podcast session, and I'm going to provide just some summary of the key points that we talked about. And those 3 key points. The first is that atopic dermatitis is a heterogeneous disease. It is reflected in a diversity of phenotype presentations and a diversity of underlying cytokine pathology. Second, JAK inhibitors are a fast-acting, powerful therapy for atopic dermatitis patients that have outperformed dupilumab in head-to-head studies. And 3, traditional immunosuppressants have less relevance today in atopic dermatitis and really should be positioned behind JAK inhibitors and biologics and used in very specific special circumstances. And so with those summaries, just Dr. Koo, do you have any final thoughts about atopic dermatitis and the role of any innovative treatments in the future?
Well, all I can say is I'm truly excited about all these developments. Um, I hate to admit, I've been in dermatology now 40 years, and I have seen the whole revolution in treatment for the benefit of patients in psoriasis in like the first 30 years of my career. And the last 10 years of my career, right, which is right now, I'm so excited to see same thing happening with atopic dermatitis. I'm so glad for the patients.
Yeah, in the end, what you just said, it's all about the patients. And for the first time, we're talking about EASI 90, EASI 100 in our atopic dermatitis patients. We're talking about itch 0 or 1, and some of the most recent studies that look at patient-reported outcomes in atopic dermatitis, focusing in on itch, the itch numeric rating scale. What they found was that patients that had itch of 2 or 3 out of 10, those patients had 40% more burden in their quality of life scores than patients that had an itch of 0 or 1. So when you're a dermatologist and you get your patient's itch from an 8 to a 4, as I brought up that example earlier, that 4 is not good enough, because the data shows that if you get it to an itch of 0 or 1, you can impact the patient's quality of life by more than 40%. And that is a very tremendous statistic that affects me clinically now, that if my patient's itch is not 0 or 1, then I'm not helping their quality of life based on this new patient-reported outcome data. And so when I'm in the clinic, my standards have changed because of what's happening in this innovative landscape of JAK inhibitors and frankly also new biologics. That whole innovation is leading towards a new threshold of EASI 90 plus itch 0 or 1. It's not EASI 90 or EASI 100 or itch 0 or 1. It's EASI 90 plus itch 0 or 1. And right now, the only therapies that are really hitting that bar are the JAK inhibitors. And network meta-analyses show that the top 3 positions, kind of what I call the gold, silver, and bronze of the atopic dermatitis Olympics, are all JAK inhibitors at the current moment. And so they're really paving the way for innovation. And innovation, that's what the LiveDerm team is about. That's what they are doing with this podcast series. So Dr. Koo, thank you so much for joining us in our kickoff podcast session, looking at systemic JAK inhibitors in atopic dermatitis. And going forward, we have a lineup of wonderful people, including Dr. James Song, Dr. Jonathan Silverberg, Dr. Ruth Ann Vlegels, Dr. Naeem Issa, and Dr. Leon Kursick. And over the next 5 months, we're going to continue to delve in deeply and talk about atopic dermatitis so that we can become better clinicians and, more importantly, help our patients really manage their atopic dermatitis better with clear skin and no itch. Thank you. Thank you to everyone for tuning in to this kickoff podcast hosted by LiveDerm. The goal of this LiveDerm podcast series is to facilitate a comprehensive and engaging conversation, providing listeners and providers with a deep understanding of atopic dermatitis, its complexity, and the nuanced approach required in its management with the advent of JAK inhibitors and other treatment modalities. And so we thank LiveDerm, and we really look forward to this LiveDerm atopic dermatitis podcast series going forward. Thank you.
Stay tuned for our next episode in this series featuring Dr. James Song, JAK inhibitors in action, effectiveness in atopic dermatitis.